Now we continue with acute tubular necrosis. Now, for acute tubular necrosis, you need to know that one. For the urine dipstick in acute tubular necrosis, in this case, we don't have a glomerular range proteinuria. Since it is the tubules, is it clear? It means that it is not the glomerule, the proteins is not going to come too much. Is it clear? So no, it is not going to be glomerular range nor nephrotic range, just going to be a non-glomerular proteinuria. Is it clear? Why is it non-glomerular proteinuria? It is non-glomerular proteinuria because there are certain, though the glomerulus is functioning normally, there are still certain small proteins that can penetrate into the glomerulus. Is it clear? Which are called microalbumins. Is it clear? They can penetrate into the glomerulus, and when they penetrate into the glomerulus, they enter into the filtrate. Is it clear? They are normally supposed to be reabsorbed by the tubules. Is it clear? But the tubules are not there to reabsorb them, so they are going to be lost into the urine. That is going to be why in the urine you have 1+ protein. When you have 1+ protein, it makes you think of a non-glomerular proteinuria, which comes as a result of an acute tubular necrosis. Now, on the microscopy, you are going to see the epithelial casts. You see brown casts. Is it clear? You see brown muddy casts. Is it clear? Which are epithelial casts, brown muddy casts, and all that is the hallmark for acute tubular necrosis. Now, the next one is for acute interstitial nephritis. For acute interstitial nephritis, see on the urine dipstick. On the urine dipstick, you're going to see leukocytes. Is it clear? You're going to see leukocytes on the urine dipstick, and on the urine microscopy, is it clear? The leukocytes are much more lymphocytic predominant. They are much more lymphocytic and not neutrophilic, because more neutrophilic leukocytes are going to be much more in the cases of in the cases of a urinary tract infection. But lymphocytic leukocytes and the leukocytes which are located in the pathology which is being proliferating, is it clear? It is the one that is going to be located in acute interstitial nephritis. Now, in order to confirm, this is just to support the particular mechanism, in order to confirm each of these mechanisms, for acute glomerulonephritis, you need to know that acute tubular necrosis, acute interstitial nephritis, you need to do a renal biopsy. Is it clear? The renal biopsy is the one that is going to, and the histopathology is the one that confirms that it is actually acute glomerulonephritis or acute interstitial nephritis or acute tubular necrosis. Is it clear? So that is how you do the investigations inside investigations for the different mechanisms of acute kidney injury. Now, so that is for the mechanism of acute injury. Now, when you investigate, the next thing that you can investigate in acute kidney injury, you have to investigate for the etiology of these mechanisms. Is it clear? So, acute glomerulonephritis, I've already said, the etiology can be post-streptococcal glomerulonephritis, that you have to evaluate if there is any streptococcus inside the throat of the child. You can do a throat swab and culture for streptococcus, and you can do also a throat ASLO, is it clear? ASLO to visualize for the antigens of streptococcus inside the body of the patient. Is it clear? So we have other elements. You can ask for hepatitis B, which causes membranous nephropathy. You can ask hepatitis C, which causes membranous membranoproliferative nephropathy. Is it clear? So those are the different things that you have to ask based on the different etiology that we have set in each of them. In case of acute tubular necrosis, it can be ischemic, can be toxic. If you have ischemic, you have to ask for urea creatinine and find for the ratio to find if the patient was dehydrated, and it's going to be dehydrated if the ratio is going to be greater than 20. So those are the different elements. Toxic, you have the different causes, the different elements that you have to find if it is toxic or not. Is it clear? And you find the level of myoglobins in blood, still by the blood test to find if it is toxic for myoglobin. If I ask for hemoglobin in blood, is it clear? So now the next thing you have, so if you want to find direct hemoglobin in blood, you ask for the level of the haptohemoglobin in blood. Is it clear? Now we have acute interstitial nephritis. You can ask for the different malignancy, proliferative disorders which can occur. Now the next thing is to evaluate for the complications. Is it clear? To see for pulmonary edema, you are going to evaluate with what? You can evaluate with the simple chest X-ray. Chest X-ray is going to just to support that there is actually edema, and you are going to have the signs of ABCD, alveolar opacity, Badwick sign, or the SchrDbb. Here you are not going to have SchrDbb lines, because SchrDbb lines are much more for cardiac abnormality, cardiogenic pulmonary edema. Is it clear? So you're not going to see the C, because C is for cardiomegaly in cardiogenic edema, so it's not going to be there. So you are going to have pulmonary edema signs, and now you need to know that we are confirming pulmonary edema. You measure the blood pressure at the level of you measure the capillary wedge pressure. Is it clear? Is the method by which you confirm pulmonary edema. Now the next thing after that, the complication, you can have acidosis. Acidosis asks for arterial blood gases to measure the pH. Is it clear? And then the next one after that, after acidosis, arterial blood gases to measure the pH. The next one after that, you ask for you ask for after arterial blood gases is measured for the pH, you can have also the next complication, which is uremia. Is uremic syndrome. Is it clear? Generally, uremic syndrome is going to occur when the urea level is greater than 100 milligrams. Is it clear? So you have to ask for the urea level. The patient can also have hyperkalemia. Is it clear? The patient can also have hyperkalemia, and you can evaluate, support the hyperkalemia by using the ECG. And on ECG, we have signs of hyperkalemia, which are tall peak T wave. Is it clear? When you have tall peak T wave, it is a sign of hyperkalemia. The second sign of hyperkalemia, you have absent P wave. You have absent P wave. You can have again PR interval elongation. You have prolonged PR interval. The next one after prolonged PR interval, Is it clear? So you can have again sine wave formation. So those are the four major signs we have in hyperkalemia. The contrary of hyperkalemia is hypokalemia, and the signs of hypokalemia, we have instead the T wave. We have the T wave. We have T wave depression and inversion, and we have the QT interval. We have prolonged QT interval. Is it clear? Prolonged QT interval. And that prolonged QT interval, to measure the QT interval, the QT interval estimated is going to be the calculated QT interval is the measured QT interval divided by the square root of the RR complex. And for you to say that the calculated QT interval is elevated or prolonged, it should be greater than 0.2 seconds. Is it clear? So those are the elements I have to do. So you need to first calculate the calculated QT interval from the measured QT interval divided by 2 RR complexes, and it has to be greater than 0.2 for you to say that you have a prolonged QT interval. And then the late complication, you are going to have torsade the point. Is it clear? So those are the different elements that you have. And torsade the point are polymorphic tachycardias. Is it clear? So those are the different elements that you can have in the complication of the acute kidney injury. We now continue with the complication of chronic kidney disease, the investigation in chronic kidney disease.